A very good morning and welcome to this session titled Future-Proofing Health Systems. My name is Nzinga Kunta. I'm a business news anchor on the public broadcaster in South Africa, and it's my great pleasure to be moderating this discussion as we take a look at the impact of COVID-19 on our collective lives and lessons that can be learned from the pandemic. The dramatic spread of COVID-19 disrupted our lives, livelihoods, communities, businesses, and economies worldwide. Today, we're going to be taking a look at how policies, partnership, and practices can ensure that we scale up health systems and adapt them in a way to ensure that there's resilience and uninterrupted care, even in times of crisis and shocks like the ones we've seen over the last 2 years. On our panel today is Jayashree K. Iyer. She's the CEO of Access to Medicine Foundation. Leif Johansson, who is the chairman of the board of AstraZeneca. Chief Minister Jagan Mohan Reddy from Andhra Pradesh. Catherine Russell, who is the executive director of the United Nations Children's Fund. We will be taking audience questions a little bit later on, but perhaps for now we'll start the discussion. Leif, I'll start with you. As one of the companies at the forefront of the response to COVID-19, what lessons would you say you've learned from the pandemic?
Well, I think you remember that we responded by making 2.9 billion doses of vaccine, delivering to 183 countries, two-thirds of which were low and middle-income countries, and at no profits. I think that was an immediate response just by saying, answering the question, can you help? And we said, we'll try and do what we could, and that worked out very well. I think the lessons in the immediate crisis really was that we need to think about going to places where we normally don't go. In our case, that meant going to academia and collaborating directly with academia, and then in a way such as to produce billions of doses of vaccine to really scale up. I think in the immediate, again, lessons learned from a government point of view should be that there need to be funding made available, decisions already having been made, like in the US, and which is now being discussed in Europe, to have funds available for the immediate crisis. Longer term, I think there are actually a few more lessons there. We are participant with the PHSSR, which is the Health, Sustainability and Resilience project that WEF and we and London School of Economics are running there. I think there's some very interesting data coming out of that. 97% of all healthcare costs is being spent at hospitals when patients present at the hospital being ill or at the general practitioner being ill. 3% is spent on trying to prevent and detect early disease. I would suggest that probably should be 80-20 or even 60-40. But for different reasons, and we can discuss what those are, that doesn't happen. I think what we can do with the PHSSR is to show pilots and countries that are doing remarkably much better by making sure that people are not getting sick rather than to treat them when they are ill. And I think that's a very solid lesson that we should try to take to heart when we look over the next couple of decades.
Jayashree, we can't speak about a pandemic and medicines without talking about how there was a disparity in access to vaccines in developing versus developed nations.
Yeah, no, absolutely. I think that the COVID-19 pandemic has definitely put a spotlight on a chronic issue in healthcare, inequity of access. You see that with the vaccines. You see the high-income countries, within a year of delivery of vaccines, achieved about 75 to 80% coverage, and in low-income countries it was less than 10%. And I think that represents, a change that needs to happen, where innovators need to think ahead on how they're improving access. I think the actions that companies like AstraZeneca has taken in prioritizing access to low-income countries makes a big difference. In our research, we've also seen that there's about 8 out of the biggest 20 companies that have been today prioritizing access by making sure that every product that's in the research and development pipeline goes through a set of criteria to see, okay, which countries is it going to be made available in. But the reality of it is actually really vast. I mean, in our research, when we analyze all the different products that are being made by the pharmaceutical industry, we see that about half of the products do not have a system in place to bring these products to low-income countries. So the inequity is huge, and we forget that 80% of the world's population live in low and middle-income countries. We forget that inequity is not only there for vaccines and medicines, but also life-saving products such as medical oxygen, which has been a long neglected issue in the healthcare crisis.
Minister Reddy, if we're talking about the crisis that some countries are still in, talk to me about what happened in Andhra Pradesh and the interruptions to healthcare there and how you managed that.
COVID was one particular pandemic that nobody ever anticipated. At least we have not seen that kind of pandemic in our generation. So it was something that was unprecedented. And the entire healthcare system, which was present till then, had to be re-looked into in order to prevent something, in order to be a formidable force. If at all something like this were to reoccur, then I think this actually taught us quite a few lessons, especially on, moving on to the importance of preventive and curative care, and also making sure that the healthcare system is available to everybody, is accessible to everybody, and also making sure that it is affordable to everybody. So all these aspects were an eye-opener to all of us. And within the limits that we had, we did everything what a country could do or a state could do. We were more focusing on tracing, testing, and treating, because we, from my state's perspective, we are short on tertiary care, because tertiary care, we were a newly formed state, and we do not have a tier 1 city like Hyderabad or Bangalore or Chennai, where private investment is huge coming into in super specialty hospitals. So since we had that handicap with us, so we wanted to get into the early stage, detecting at the early stage. So we conducted almost 44 rounds of house-to-house survey. We had a robust system in place with the village secretariat at every village, a volunteer system for every 50 houses. We had 42,000 ASHA workers, also the volunteers dealing with health issues, be present. And all these factors put together, we initiated this process of house-to-house survey. And in this close to 2 years of this pandemic, we've conducted almost 44 rounds of house-to-house surveys. So that was one of the primary reasons as to why we could cut the mortality rate. Even though the country's mortality rate was 1.21%, our state's mortality rate was the lowest in the country, 0.63%. So that's one of the primary reasons.
So, Catherine, we're hearing about the challenges that have been experienced due to the COVID-19 pandemic on the healthcare system, but of course it's not alone there. There's also a migration crisis that's testing already stressed healthcare systems, with disruptions reported in essential services and care in over 90% of countries.
I think the way we look at it from UNICEF is that there are cascading crises for children. Certainly the COVID crisis was a huge challenge for children. It drove, we're estimating, another 100 million children into poverty. It kept children out of school for months, if not years, right? It interrupted routine vaccinations. I mean, COVID was devastating for children, but you're right, it's not the only crisis. We also have conflict in Ukraine, which is ending up in millions of people being disrupted there. Certainly, children are leaving the country. Children are moving around in the country, so displaced in the country. But it's also, I'm sure people have seen this in the press, but it's affecting wheat prices and oil prices, and that also has an impact on children. I was 2 weeks ago in Ethiopia, in the Horn of Africa, to see what's happening to children there because of the food shortages, and it's devastating to see it. Populations are moving because the animals are starving to death. People are severely malnourished, and I visited children in a hospital who were so acutely malnourished that you walk into the room and it's completely quiet because the babies are too weak to cry. So all of these crises are sort of impacting each other, reinforcing each other, and the impact on children is devastating. And I think when you look at, on the healthcare side, having decent primary healthcare in these countries would be incredibly helpful, and that exists in some places, but unfortunately not enough.
Mm-hmm. Lev, when it comes to the issue of sustainability and pricing, which can also be a barrier to access, what are you thinking of as AstraZeneca, and also when it comes to your carbon footprint?
Well, first of all, I think what we're seeing now are many of us, governments, but also companies, realizing that health and sustainability goes together, and especially so with climate change. And good examples of this is respiratory disease with air pollution, probably produces millions of deaths every year. Contagious disease is certainly one of those, but also everything that has to do with cancer exposure to different substances, etc. In the case of climate change, we are trying to be doing our part. About 4 to 5% of the world's global footprint is actually coming from the healthcare sector. We are trying to be doing our part, in our case, by having reduced since 2015 about 60% of our carbon footprint up until now, and we are planning to go zero before 2026 in scope 1 and 2, and then 2030 also in scope 3. All of those are powerful measures, and of course the reason that we are doing that is that we realize that there is a real tie between the two. What is good, I think, is that the world is realizing that also, and I think there is a way to promote now both healthcare systems, sustainable and resilient health and healthcare systems, and climate at the same time. Then over time, when it comes to access to medicines, that's going to have to be done by, over time, building resources in broader continents. The only alternative to that I see is really good trade agreements, but they then need sanctions so that we don't end up in the vaccine nationalism that we had over the past couple of years.
Speaking around that issue, Jay, just talk to me about the Access to Medicine Index. What is this?
So the Access Medicine Index is a biennial ranking of the pharmaceutical industry's efforts in improving access to healthcare for about 106 low and middle income countries. And basically, it's a research system where we evaluate the efforts of different pharmaceutical companies. So this is the biggest pharmaceutical companies in the world, the likes of AstraZeneca, who in the last index sits in the top 10 of that ranking. And what it ends up doing is we come up with best practices, we come up with gaps and opportunities in looking at issues such as future pandemics, issues such as children's healthcare, whether specific populations in the least developed countries are also being taken into account when you think about market access issues itself. And we bring the research to different settings. So companies use